Starting with the second chapter of respiratory system from marrow, that is foreign body aspiration, congenital lung anomalies and asthma. Let's start with the foreign body aspiration. It is commonly seen in age less than 2 years of age. Most common foreign bodies are the peanuts and coins. Lower airway body aspiration. Location is bronchus. Right and left bronchus are equally affected. How will be the presentation? Sudden onset cough will be there, fine, and there will be choking and gagging and breathing difficulty and presence without fever. This is one of the important clues, that there will not be any fever in the child and sudden onset cough will be present. All the symptoms will be very sudden onset. Most common presentation is sudden onset cough, fine. And upon auscultation, there will be unilateral wheeze heard because the foreign object most probably would have obstructed one of the side, and due to that there will be wheezing from that side only. Further course, if the initial symptoms resolve, then later presents with complications. Okay. Chronic cough and wheeze, localized to one side, recurrent infection, bronchiectasis, that is abnormal and irreversibly dilated bronchi. Bronchiectasis is this. It is abnormal and irreversibly dilated bronchi. Fine. Second one is airway obstruction. If the airway obstruction by the foreign body is complete, no, so then it will lead to segmental atelectasis. And if it is partial, then it will lead to hyperinflation of the lungs and Boyle valve effect and air trapping. Air trapping will be present, okay. Initial symptoms resolve, later fine, this all is done. What we read was airway obstruction if present, if complete then lead to segmental atelectasis, and if partial will lead to hyperinflation of the lungs. Okay, moving ahead, air cannot pass through a completely blocked bronchus, so there will be no inflammation of the it's inflation of the respective lung segment leading to segmental atelectasis. Because of this complete blockade of the bronchus, no inflation and no air can pass through that. This will lead to what is atelectasis, that the alveoli will collapse and there will not be any air exchange through those alveoli. What is this Boyle valve effect? During inspiration, air goes in, and during expiration, no air goes out. This leads to air trapping, right? This is here. And this air trapping leads to hyperinflation of the lungs, because inspiration, air is going in, but during expiration, no air goes out. Fine. Moving ahead, chronic presence of the foreign body is suspected when a child has recurrent pneumonia involving the same side of the lung and also the same segment. Fine. So if a child is having recurrent pneumonia involving the same side of the lungs and the same segment, then you have to suspect chronic presence of a foreign body. Okay. Only 10 to 20% of the foreign bodies are radio opaque. All the foreign bodies may not be seen on the X-ray. Only 10 to 20% of the foreign bodies are radio opaque. Fine. Then if any child with suspected foreign body aspiration comes to you, you can't only rely on the X-ray, because we read, right, only 10 to 20% are radio opaque. Suspicion of the foreign body aspiration. How will you suspect that? If the history is suggestive of sudden onset symptoms, fine. If there are focal abnormal lung findings, and if there is an abnormal X-ray. If any 2 out of the 3 is present, the suspicion is strong and the removal of the foreign body is initiated, and treatment is via rigid bronchoscopy guideline and removal under the general anesthesia. Fine. Rigid bronchoscopy guided removal is done. And what are the 3 conditions, out of which 2 must be present? There should be history suggestive of what? Sudden onset of symptom. Focal abnormal lung findings should be present, like one part of the lung is involved, one side of the lung is involved, that kind of abnormal X-ray. Now upper airway foreign body aspiration presents with stridor. Okay, so the treatment is immediate removal, depends on the age of the child. If age is more than 1 year, then we can do Heimlich's maneuver, that is upward and the backward epigastric thrust from behind. And if the age is like less than 1 year, the child is infant, then how wrong is this statement that the child is infant? Shit. It's if the presenting patient is an infant, then we have to give back blows in the prone position between the shoulder blades 5 times. Then in the supine position, chest compression using 2-finger technique over the lower sternum 5 times, and repeat it alternatively until the foreign body is expelled. Right, we have what we have to do: in prone position back blows, in supine position chest compression, and repeat this alternatively until the foreign body is expelled. Fine. Moving ahead, congenital lung abnormalities. First that we are going to read about is the congenital lobar emphysema, also known as the congenital lobar hyperinflation. Cause is what? Cartilaginous bronchial dysplasia, developmental defect it is, and leading to the partial ball valve effect and result in air trapping and hyperinflation. Okay, cartilaginous bronchial dysplasia. Site is mostly left upper lobe and the right middle lobe. So you can see, right? This is the right middle lobe. One second. This is the right middle lobe and this is the left upper lobe. Characteristic features is there will be midline shift. We can see, right, here this structure, heart is being shifted, and there will be midline shift and respiratory distress in the newborn. Investigation of choice in congenital lobar emphysema is CT chest and treatment is by lobectomy. Oh, okay, moving ahead. Pulmonary sequestration. Non-functional pulmonary tissue that does not communicate with the tracheobronchial tree. This is the pulmonary sequestration, that there is a pulmonary tissue which is non-functional and it does not communicate with what? Tracheobronchial, the normal tracheobronchial tree. Blood supplies from the systemic arteries, classified as intralobar or extralobar. Extralobar has separate pleural covering, intralobar is covered by the common pleura. Site is mainly lower lobes of the left lung. Complication, there will be recurrent respiratory infection. Investigation of choice is CT chest and treatment is surgical resection. This was all about this. Now the second condition, I think, is congenital pulmonary adenomatoid malformation, CPAM. Previously called as the CCAM, that is congenital cystic adenomatoid malformation. Now it is called CPAM, congenital pulmonary adenomatoid malformation. Most common cause of the cystic lung disease in newborn. See, you can see the cysts, right? Like here, 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 here. These all are cysts. So it is the most common cause of cystic lung disease in the newborn. There will be unilateral hematomatous lesion. Most commonly the site is left lung. Presence either in the newborn or in the older children as recurrent infection. Sometimes it is asymptomatic also. There is risk of malignancy, either sarcoma or carcinoma of the lung, and treatment is by the surgical resection within 1 year of the age. Okay. Now moving ahead, asthma. Asthma is characterized by, main feature of asthma is bronchoconstriction and the patient presents with the wheeze. Prerequisites to diagnose the asthma are, what should be present? There must be a trigger by allergens or infection. So first important thing we read was trigger should be present. Second, this is asthma is reversible condition, either spontaneously or by using the short acting beta agonist. It is a reversible condition. Then the thing is recurrent episodes, at least 3 or more. In asthma there are recurrent episodes, okay, and the presence of risk factors should be there. These are all the prerequisites. So what risk factors? Either history of asthma or allergies in parents, other allergic disorders like atopic dermatitis, sinusitis and allergic rhinitis, and male gender, low socioeconomic status, repeated exposure to the tobacco smoke. Triggers of asthma include dust, pollen, exercise, stress and respiratory infections also. Fine. So these were all the prerequisites to diagnose the asthma. We read about 4 prerequisites. First one is the triggers. Triggers should be present and that could be allergen or infection. We read about the triggers here. It is dust or pollen or exercise or stress or even respiratory infections, right? Second thing we read about diagnosis of asthma is reversible. It is reversible either spontaneously or by or by using beta agonist. Then there will be recurrent episodes. At least 3 episodes or more should be present, and presence of risk factors like history of asthma or allergies in the parents, and other allergic disorders like the atopic dermatitis or sinusitis or allergic rhinitis. And male gender it is more common, and low socioeconomic status and repeated exposure to tobacco smoke. Now the types of asthma. It is divided on the basis of the trigger, right? If it is atopic, which is most common, that the trigger is extrinsic, trigger is mostly an allergen, right? And non-atopic, in which the trigger is intrinsic, like viral infection, and others were like drug induced, caused by aspirin and exercise. Fine. So these were the others. And non-atopic, we read the trigger were intrinsic, that is viral infection, so it is non-IgE mediated. But if the trigger is extrinsic like any allergen, then it is IgE mediated. Okay. Cough variant asthma is also present with a recurrent cough seen in young children. Now, what are the investigation that we can do to diagnose the asthma? First one we are going to do is spirometry. Then we can do is just spirometry is given. Okay, fine, let's go ahead. Evidence of airflow limitation will be seen on the spirometry. There will be decreased FEV1 by FVC to less than 0.8. In adults it is 0.7, but here what is FEV1 by FVC? FVC is the functional vital capacity, and FEV1 is the forced expiratory volume in the first second. How much lung can be expired forcefully in the first second is the FEV1, and that will be decreased because there is an obstruction. We read, right, bronchoconstriction is present. So due to that the FEV1 will be decreased, so it will be less than 0.8. Bronchodilator response, right, after giving a bronchodilator there will be an increase in the forced expiratory volume in first second by more than 12% after initiation of the bronchodilator like salbutamol. Okay, so these are the things that if seen on spirometry then we can diagnose asthma. First one, FEV1 by FVC less than 0.8. Second one is that FEV1 should be more than 12%, should increase by more than 12% after any bronchodilator like salbutamol. Third thing is exercise challenge. On exercise challenge there is worsening of FEV1 by more than 15%. Okay. And then daily PEF or FEV1 monitoring is done. There is AM/PM variation present, or day-to-day variation. There is PEF or peak expiratory flow. So the variation here is it is more than 20%. If the variation is more than 20%, then it is suggestive of asthma. Exhale nitric oxide of more than 20 parts per billion is present, right? Will be present in the spirometry. So what we saw in the spirometry is this, that is low FEV1 upon FVC, FEV1 more than 12% in the that is in the bronchodilator response. Exercise challenge, there is worsening after exercise of more than 15%. There is AM/PM variation of more than 20%, and there is exhaled nitric oxide of more than 20 parts per billion. Coming to the management of asthma, long-term management and management of the acute attacks of asthma. Long-term management, we do stepwise management. First, now we have divided long-term into intermittent, and persistent. And persistent is again divided into moderate persistent and severe persistent. So let's start with intermittent asthma only. Intermittent asthma is characterized by infrequent symptoms, right? The symptoms are not very continuous or frequent. The child is normal in between the attacks. So we just give treatment by the short acting beta agonist as and when needed. Fine. Starting with the persistent asthma, it is divided into mild persistent, moderate persistent and severe persistent. Mild persistent, there are day episodes of more than 2 per month. Okay, and there are nighttime awakening of more than or equal to 1 per month. Day episodes 2, and nighttime awakening 1. At least 1 and at least 2. Okay, and treat daily with low dose inhalational corticosteroids. In mild persistent only, we have to give low dose inhale corticosteroids, either budesonide, fluticasone or beclomethasone. Fine. Moderate persistent daily attacks or the need to use the SABA daily, treat with the medium dose inhalational corticosteroids and low dose inhalational corticosteroids with LABA. So we have a choice here. If moderate persistent, when we are calling moderate persistent, if there are daily attacks or need to use a SABA daily, then we are calling it a moderate persistent. Now in this case, what we have to do is we have to give medium dose inhalational corticosteroids. If more than 2 episodes per month were present and more than 1 per nighttime awakening was present, we were given daily but low dose ICS. Here daily attacks are present and need to use SABA daily is almost present, then we are giving medium dose ICS, or we can pair the low dose ICS with long acting beta agonist. Long acting beta agonist like salmeterol and formoterol. Okay. Now the severe persistent one, there are daily attacks but continuous throughout the day and night. There is significant limitation of the physical activity. So on treatment, we can give treatment by high dose ICS and LABA. That is long acting beta agonist is common in both the moderate persistent and severe persistent, but there is this, here is low dose ICS, here is high dose ICS. Fine. An alternate choice as an add-on drug for better control, we can also give montelukast. Moving ahead, sustained release theophylline can also be used, and oral short course steroids or the alternate day steroids can also be used. Now the oral short course steroids are used only when the asthma fails to respond to every other drug to avoid the systemic complications. Fine. So when we are giving oral steroids, until here we were giving only inhalational, fine. But when oral steroids are given, when the asthma fails to respond to every other drug asthma medication devices, there is a meter dose inhaler given along with a spacer. Small amount of the drug goes in with every puff. If less than 4 years, face mask, spacer and the MDI is used. If 4 to 12 years, spacer and MDI is used, and more than 12 years, only MDI is used. Okay. Rotahaler, also called the dry powder inhaler, and used in more than 5 years. Rotacap is a capsule containing the drug, and nebulizer can be used to administer the medicines in a hospital setup. This is the management of acute attack of asthma. Fine, let's start. If a patient is presenting to us with acute attack of asthma, first we will give is a short acting beta agonist like salbutamol. 1 puff every minute, up to 10 puffs can be given, or we can do a single nebulization. Fine, even after all this, there is no response. Then we can give oxygen if SpO2 is less than 95%, or start the oral prednisolone at the dose of 1 to 2 mg per kg, and then we assess after 1 hour. If there is improvement, then we can continue the SABA, because after giving SABA and oxygen only there is improvement, so we can continue the SABA every 6 to 8 hours for the next 24 hours. And if even after giving SABA only there was response present, then we can again symptomatic relief and there is increase in the PEFR by more than 80%, we can again continue the SABA. Fine. But even after giving oxygen and starting the oral prednisolone, and if we assess after 1 hour there is no response, then we have to give nebulization of the salbutamol, ipratropium and injection hydrocortisone. 3 things are to be given after starting the oral prednisolone: salbutamol nebulization with ipratropium and injection hydrocortisone at the dose of 10 mg per kg. Then we have to assess after 2 hours and we look for the response. If response is present, then SABA is continued and oral prednisolone is given for 5 days. First we give injection hydrocortisone, later we have to give oral prednisolone for 5 days. If there was no response, then what could be done? We can give injection theophylline. Even after giving this nebulization and injection hydrocortisone, then we can give injection theophylline and IV magnesium sulfate infusion, and if still there is no response, then the ultimate is the mechanical ventilation. Tapering of the oral prednisolone is not required. Oral steroids followed by the IV steroids is the norm. Okay. Fine. What we did was starting with the short-acting beta agonist, 1 puff every minute or single nebulization. If there was no response, then we give oxygen if SpO2 was less than 95% and started on oral prednisolone. If response was present, then we continued the short-acting beta agonist for the next for every 6 to 8 hours for the next 24 hours. And if no response was present even after 1 hour, then we again give nebulization, but with salbutamol and ipratropium and injection hydrocortisone. Initially, we gave oral prednisolone, right? Here we gave oral prednisolone at 1 to 2 mg per kg. Then we shifted to injection hydrocortisone and 10 mg per kg. Then we have to look for the response. If response is present, no, then we shifted to oral prednisolone. But if no response, then again we give injection theophylline or IV magnesium sulfate infusion. And mechanical ventilation is the ultimate choice if no response after all this. Tapering of the oral prednisolone is not required. We read that. Now coming to the life-threatening asthma. If any child who is presenting with silent chest, there is no air entry, there is cyanosis, there is altered sensorium, there is poor respiratory effort or labored breathing, and the SpO2 is less than 90% and PEFR is less than 30% of the expected, no, then that is called as a life-threatening form of asthma. What is present? Silent chest, cyanosis, altered sensorium, poor respiratory effort, SpO2 90 se kam, PEFR less than 30. On treatment, what we have to do is injection adrenaline and the terbutaline subcutaneously, injection hydrocortisone and nebulization with the salbutamol and ipratropium. We are giving all kinds of drugs. We are giving SABA, we are giving steroids, and we are giving adrenaline also. Injection adrenaline or terbutaline subcutaneously, injection hydrocortisone or nebulization with the salbutamol and ipratropium. Now we will discuss the next chapter in next video. Thank you.